Unfortunately, it's the latter. It's so that we can maintain their current level or make them better. We cannot cure any of these diseases. The one caveat would be if somebody had maybe a lung transplant and was able to, you know, gain really a good set of lungs with no problems, no rejection, and had a terrific response that way, then one could theoretically say they were cured. I think that if you look at that, we know that they have less ability to manage their airway clearance techniques. They don't push themselves because they're often very afraid. So they become more sedentary and more dependent. And then they get put on more medications or have more flares because they aren't using their medicines appropriately. And so steroids come in to being used more often. So I think that we're able to ward off some of those things happening because they get a full line of services to where they can have questions answered, and they have a contact person 7 days a week that if they have a question, they can call. And then we kind of are the liaison between them, their primary, their pulmonologist, their cardiologist. So I think that, you know, that helps with the coordination of care. At UC Davis, we have a program called the ROAD program. So we have patients who are in the hospital who have COPD, and they're identified by our other team as having a high risk for re-exacerbation and admissions. They're taken care of, they're funneled into that program and then through us. And then now we're actually instituting the next phase of the palliative care part. So people who have so advanced of lung disease, we know that having a progressive palliative care model is important. So it's disease directed. Anything that you can treat that's reversible, such as, let's say you have pneumonia, you would treat that. But you know when you have to start switching to getting these other things. So we're kind of the center part to the spokes in the wheel and help from the beginning towards the end trajectory. The data is just now starting to surface about having pulmonary rehab and interstitial lung disease, pulmonary hypertension. That was not done before. So it does show that those conditions, patients do get better, but the data is not as robust as in COPD. We know that certainly it makes a difference in their clinical outcomes and their re-exacerbation rate, their readmission rate to the hospital. Mortality, maybe not so at this point. Gender differences also are coming up, and myself and my colleagues did some studies on beginning studies looking at gender differences, such as women's upper body strength compared to men and across different diseases. So that's just now starting to come out, where we're kind of taking that onion and peeling those layers back and seeing whether or not there's a difference, because I think we're going to have to definitely tailor that a little bit better for people who aren't COPD patients. It is available. Most larger cities would have that. And then even here we have several programs that are in the community and then the university. If you have a wait list, then sometimes we'll refer them to a community program. Or if they are in Folsom or Rockland and they want some place that's a little closer for them, then we'll reach out to those, and those programs are available. Kaiser has them also. So most larger cities will have them. Smaller ones, no. They are all created equal in that they all have a multidisciplinary approach to them. They are not all created equal in who spends the time with them to what capacity. And there's a difference in some of the programs whether they're certified or not certified. If they're certified, they have to meet a little more stringent guidelines for Medicare and so forth. I think also that because we're a tertiary center, you're looking at patients that have transplant and those kind of things are received at elsewhere. And a pulmonary hypertension center, you're going to get sicker patients than what's in some of the community programs. That would be their pulmonologist, most often is the highest referral, but their primary care doctors can refer directly. So if somebody had COPD and was symptomatic, it doesn't matter that they maybe have a more moderate level. If they're very symptomatic, then they should be referred. And then we'll go through whether or not they would meet qualifications, because we don't want them to get a bill because Medicare won't pay for something. So there's very stringent standards that are there, and we will let them know whether or not, yes, you qualify, or maybe we can design something that you can actually do at home or in a gym if they're in better health. So we'll try to help them out in that capacity.